Good morning. Welcome to the Department of Medicine Ground Rounds. Today we have what I'm sure is going to be a terrific lecture, and I'll introduce the speaker and Dr. Boley in a second. A couple of things to note. On this day was the birth of Johannes Fibiger, Johannes Andreas Grib Fibiger. He was a Danish pathologist, and this was in 1867. And it's interesting to me because he discovered what we now know as Ganglionium neoplasticum, which took me a little while this morning to kind of come up with. It turns out this is a nematode that when he identified it, it was called Spiroptera carcinoma, which is a weird term for a worm. And what he described was that if he infected rats with this nematode, he consistently found that they developed gastric carcinoma. And that was the first demonstration in 1926 of induction of carcinoma in an animal model, which has been important ever since for further research in cancer. So Johannes Fibiger was born on this day. On this day was also the birth in 1857 of Max Carl Erdwin Ludwig Planck from the Max Planck Institute, well known as professor of theoretical physics, and of course the introduction of quantum theory in 1900, for which he won the Nobel Prize of 1918. But today is about cardiology, so there's another Ludwig you should know about. His name is Carl Friedrich Wilhelm Ludwig. He died on this day in 1895. He's also a German physiologist, well known for being one of the creators of modern physiology, and he studied the heart and cardiac activity. He invented the chemograph in 1847, where he could measure and monitor blood pressure. He also did a lot of work on blood gases, and he invented the mercurial blood gas pump, where he can extract blood gases from the blood and study them. And he also was the first in 1856 to keep an organ alive outside of an animal. He took you remember high school, you took the frog and you took the heart out and you saw it pumping on your desk. He did that, okay, back in 1856. First man to do this, Carl Friedrich Wilhelm Ludwig. Now, of course, we come together to learn about current events. So a couple of things to know. Is Stuart Orbeck here? There he is. I am told that this is your 90th birthday. Is that correct? I could then move on to singing happy birthday to you. I will not do that, but happy birthday. Great to have you here. Tara Schapmeyer, is she here? I am told that Tara Schapmeyer in internal medicine won this year's Association of Oncology Social Work and American Cancer Society Leadership in Oncological Social Work Award. So if you see Tara, congratulate her. You have to say the whole term when you see her. Tom Dews, Philip Brassoud, Ishram Mehta were inducted into the Alpha Omega Alpha. Are any of them here? There he is. Congratulations. I don't know if Nina Vasavada is here from nephrology. So Nina Vasavada won this year's Richard Spear MD Memorial Essay Contest of the Greater Louisville Society. So we're looking forward to looking at her essay. But it's interesting because Ikram Sohail from Cardiology won this same award in 2012. So we have a lot of good people here who submit important information to that journal. And I now want to introduce the introducer, Dr. Roberto Boley, who come up here to talk about our speaker. But why don't you come up here? Because I want to say something about Dr. Roberto Boley, who I just learned is the winner of the 2015 Peter Harris Distinguished Scientist Award. This award is an international award. It's provided by the International Society for Heart Research. It's the highest award bestowed to their members. It is internationally recognized, and Dr. Roberto Boley continues to bring visibility to this organization, and we're proud to have you here. Congratulations, sir.
Thank you very much, Jesse. Appreciate your words. So before I get to our speaker, there is one important date that Dr. Roman missed, although technically it was 2 days ago. It was April 21st rather than 23rd. Does anyone know in this room what happened on April 21st, 2,768 years ago? Come on, you guys are academicians. You should know these things. You are erudite, cultured, academic people. So, on April 21st, 753 BC, was Romulus that founded Rome. And so they celebrated the birthday 2 days ago in the streets there and so on. So I thought I would let you know that. So I'm very happy to introduce today Dr. DeFilippis, one of our rising stars. Andy graduated from Georgetown University School of Medicine, did his residency at Emory, and then stayed on at Emory as an instructor and then as an assistant professor while receiving his Master of Science in Clinical Research. Then in 2007, he saw the light and decided to be a cardiologist, and went to Johns Hopkins to do his fellowship in cardiovascular medicine. And in 2011, we were fortunate to recruit him here as an assistant professor of medicine. He is the medical director of the cardiac intensive care unit at the Jewish Hospital. He is also director of preventive cardiology and the co-director of the AIM clinic here at the ACB building. Andy has clearly established himself as one of the most promising clinician scientists we have in the department, and actually said one of the few true clinician scientists we have. He is a purebred, bona fide clinical investigator who is committed to research and teaching. He has published over 30 papers, including, in addition to 10 editorials, has received a number of grants already. A grant from the American Heart Association, is currently an investigator in the COBRA grant under Dr. Bhatnagar on obesity and diabetes. He's also a co-investigator in the ATRAC grant of the NIH on tobacco regulation. He has received really an unwieldy amount of money from the private industry. Most recently, $500,000 from AstraZeneca, soon to be another $500,000 from Roche Diagnostic and other companies, and has established a program looking at cardiovascular risk markers, particularly in patients with acute coronary syndromes. He has worked very assiduously, sometimes under difficult conditions. He's a self-starter, he's a very driven, very motivated investigator, and that's the most important quality of a successful investigator, to be driven and motivated. And he will not take no for an answer and will keep going and going in a doggedly fashion. So we are very proud to have you here, Andy. Thank you for your contributions, and we look forward to your lecture. Thank you.
Introduction, and thank all of you for giving me this opportunity to talk to you today. Today I want to talk about cardiovascular risk prediction. As all of us are aware, the most common cause of morbidity and mortality in our patients and in our lifetime for all of us here in the U.S. and now worldwide is cardiovascular disease. Okay. Sure. Should I turn this other one off? Very good. Very good. Okay, so this is a disclosure slide. I don't think there's anything that could be perceived as biasing me towards today's talk. I do some disease state education on hypertriglyceridemia and some grant funding, but are mostly related to my related but distinct research project in risk prediction for acute myocardial infarctions. My objectives for today are to look at cardiovascular risk factors. We'll talk about what they are, how they're used to estimate cumulative cardiovascular risk, the shortcomings of the guideline recommended and the risk scoring systems that we use in clinical practice today and ones that are recommended in the guidelines. And then finally, how I recommend going about evaluating cardiovascular risk. Okay, so the greater the risk, the greater the benefit. And this is particularly important in prevention. We have patients coming to us that don't have a disease or an ailment, but we want to protect them from developing disease. And certainly prevention is the best cure. However, you need to balance that against a risk. So you have someone who doesn't have any disease state at all, and you want to expose them to a therapy, and all therapy has potential risk, whether that be from pharmacotherapy side effects, whether it's financial risk, people's time, energy, and so forth, or a risk for the entire healthcare system as a use of resources. There's always risks involved in any therapy that we do. Estimating this risk is complicated. It's predicting the future, and predicting the future is never easy. So we have to balance this act of risk and benefit, and knowing someone's underlying risk will allow us to know how much risk to take to prevent that occurrence. This whole concept of risk factors related to cardiovascular disease and calculating risk started with the Framingham Heart Study. This started a long time ago, 1948, and led to a tremendous amount of discoveries. But although I want to just point out a few things about Framingham and the history of this risk factors and risk factor estimators on this slide, which is although Framingham started in 1948, it wasn't until 1961 that the term risk factor was really introduced, and we learned a lot about all these risk factors, and not until 1998 when Peter Wilson came up with the first risk score calculator, where he was introduced the Framingham risk score, which you'll see here on this next slide, took into account multiple different risk factors and what their cumulative risk was to the patient. So getting a global sense of what their cardiovascular risk was going to be over 10 years. And this was pretty straightforward then. You would get different points for different risk factors for cardiovascular disease, like age and your cholesterol and your blood pressure and whether you smoked. And you would add up these points, and it was associated with a 10-year risk of having a coronary heart disease event. These days, we don't use those charts, but we plug them into our phones or our computer, and this is just, this is the NIH's webpage where you could just Google and find the Framingham risk score, and you'll type in the risk factors, it'll give you 10-year risk. The score is different for men and women, and multiple other scores have been developed since that time. So the original Framingham coronary heart disease, but then it was expanded to cover all cardiovascular disease. In the early 2000s, the guidelines picked up on risk prediction, and they made some modification, but it's basically the Framingham risk score. But this is the first time that a risk score became part of recommended guidelines for evaluation and treatment of cardiovascular risk factors. A little later came out the Reynolds risk score, which was independent of the Framingham risk score. And then most recently, in 2013, the American Heart Association and American College of Cardiology recommended a new cardiovascular risk score, which we're going to look at today. So how important are these risk scores in our clinical practice? So these are the 2013 guidelines for the treatment of cholesterol. Steve Wagner reviewed these at Grand Rounds a few months ago. And what's important to note about these guidelines is this: one of the salient features on the guidance of who should receive statin therapy for cholesterol treatment is based on your cardiovascular risk, your total cumulative cardiovascular risk over the next 10 years. You could see here in this algorithm for primary prevention, if you have a calculated risk score of more than 7.5%, the next 10 years, you're recommended to take moderate or high dose statin. And then for this 5 to 7.5 risk category, it's a softer indication. And we're really going to concentrate today on this really more firm recommendation in the guidelines that if your calculated risk is more than 7.5 over the next 10 years, that you should be on statin therapy. This being such an important piece of treatment recommendations, in 2013 released with those guidelines and the hypertension guidelines and obesity guidelines was also a separate document on the recommendation of how to assess someone's cardiovascular risk. And this document goes through how they created and how they are recommending the use of this AHA-ACC risk calculator. So what's the problem? The problem is the applicability of these risk scores to modern populations has been questioned. You know, the Framingham risk score, the original, which remains a part of the new risk score, is based on a homogeneous Caucasian male-dominated bunch of men, really, in Framingham, Massachusetts. And there's been multiple studies since the release of that Framingham risk score in the late 90s that show that it doesn't work as well in other more ethnically diverse populations throughout the U.S. and throughout the world. The new risk score, as I noted, it still does include the Framingham offspring study. So what is this? These are the people that these risk scores are based on. The new risk score, they did something that I thought was very productive, which is they increased their power to predict by combining multiple cohorts that were followed for cardiovascular risk. So how is this done? So the Framingham risk score, ARC, CHS, and Cardia, they all enrolled patients in an observational study. They measured all their baseline risk factors, and they followed them for a decade or more to see who would have a cardiovascular event. And then they could retrospectively look back and say, well, who was at risk for having these events? And the new cohort, and sometimes it's called the pooled risk score, they used all of these cohorts and looked at patients that were covered, followed for 10 years to devise their new risk score. The risk score is fairly similar to the old ones as far as what variables are included. They include one more variable, which is African American ethnicity. So now in the new risk score, you could say whether your patient is white or African American, and their score is different for those two different ethnicities. Also to point out, some of the outcome, what these scores are predicting are slightly different, but certainly the new risk score is all cardiovascular, including stroke, which is a change from the older guidelines, which was just coronary heart disease. These scores the new score is extremely complicated. It is not something that you could calculate on a notebook. This is just one of 4 pages showing all the variables in the new combined risk score. Now, it's not that they have more variables as far as they included things like other than blood pressure and cholesterol and so forth. It's that they include all these statistical interaction factors of how blood pressure interacts with cholesterol and whether you're a smoker, whether that your cholesterol affects your cardiovascular risk differently. And so they have all these interaction terms. So you really need to use a web-based or a PDA-based application. The other interesting thing that this new risk score does, that we're not going to talk about, they also make an estimate of lifetime risk in addition to your 10-year. But the guideline therapeutic recommendations are all made on this 10-year risk of having a cardiovascular event. So we wanted to ask a pretty simple question, which is the scoring system valid and accurate? When any new diagnostic or even therapeutic comes out, it gets compared to what we're currently using in clinical practice. And here's where I feel the new guidelines fell short. There was really no comparison to the risk scores that were currently in use, whether it be the Framingham risk score or the Reynolds risk score. So myself and several people I've had the the privilege of working with in Mesa set out to use the multi-ethnic study of atherosclerosis to test and compare the new risk score with 4 other commonly used cardiovascular risk scoring systems. This is the team. I do want to point out Chris Karuba here. He's a graduate of this medical school. He started as an OBGYN intern and then had a skiing accident that took him out of his internship. He came back to Louisville, and that's the time at which I met him. He came to my office and told me that he was interested in research and epidemiology, and he started working with me on this project. He then returned to Colorado, but as an internal medicine intern. So he's now in his between his 2nd and 3rd year of internal medicine. So our objective, looking at when Mesa was set out in this group, Mesa was thought of in 1999. What I'm going to try to convince you is that Mesa as a cohort is very representative of the patients that we see in clinic and want to estimate their cardiovascular risk. This study was set up, like I said, the other cohorts where people were enrolled, and in Mesa, they were enrolled in 6 different sites throughout the country to make it an ethnically diverse study that included whites, blacks, Hispanic, and Chinese Americans. There was almost 7,000 participants, adults, and it was gendered balanced, with the half being women. So then these Mesa participants were followed very closely for now more than 10 years. They had 5 in-person exams by a physician. This is an extensive exam day. It lasts all day because Mesa was also looking at other measures to predict risk, like having a coronary calcium score, and all kinds of measures were made. So it was a full day that the subjects would come in, a very extensive history, physical, and testing. And then they got a phone call at least once a year to ask them how they were doing if they had any events. If they were in the hospital, all those records were obtained and reviewed by the Mesa committee, so forth. And they were particularly, these events were adjudicated, meaning records were examined and at least 2 physicians had to agree on the diagnosis. If they didn't, a 3rd physician would come be a tiebreaker, a very formal setting to adjudicate all the cardiovascular events. So we simply wanted to know, how well do cardiovascular risk models work? So we had their baseline data, and a very extensive baseline data from all the 7,000 Mesa participants, and then we knew over the next 10 years who had a cardiovascular event or not. How well were these new risk prediction scores able to predict the number of events in the Mesa cohort? That would basically be calibration. How well are these risk scores calibrated for predicting risk scores? So we compared that. We had a mean follow-up of 10.2 years, and we adjusted for length of follow-up on those that didn't have a full 10 years. So these are our results. Kind of sheepishly, this is not our graph that we had in our paper that we published in February of this year, but this is the editorial that went along with it, and I just think it's such a great graphic, I wanted to show it first. This is how the risk scores performed. And this up here is if they overestimated, the bar would go up, and if they underestimated. So when we looked at all the events that were there and how many of these risk scores predicted, these risk scores, almost all of them, except for the renal score, significantly overestimated how many events we should have been seeing in these cohorts. You see here the original Framingham, about 60% overestimation. The Framingham cardiovascular disease did a little better in the total population. The guidelines, so this I would argue is the most commonly used, was well over 100% overestimating how many events. We saw many less events than were predicted by this. The Framingham risk score performed very well. You see, it is hard to predict the future, and this is almost spot on. And the new risk score arguably really didn't do much better than the older ones. Looking at this, I don't know if Nancy's here. She asked me if I was going to cover if there was gender differences, and there certainly are. This is the graph we included in our publication, and these are the total amounts of discordance that you saw in that last graph. You could concentrate on this column. But if you look at men and women, you can see that overestimation is higher in men. than it is in women, but there's still significant overestimation, especially looking at the new risk score, 67% overestimation of risk in MESA with the new risk score. The first question that we had was, is this risk throughout the continuum? Meaning, if you're only overestimating risk, so between someone having a 50% chance and a 60% chance, doesn't really matter, right? They're well over the threshold of where you would consider treatment. And there is a little hint of bias towards more overestimation in the higher risk groups in some of these graphs. But for the most part, you could see, if this is unity here being perfect estimation, that the majority of risk is, the majority of deciles of risk is overestimating. What these dots represent is, so say for the new risk score, we took the whole population, we calculated the risk for everybody, say risk ranged from 1% to 30%. Then we broke it into deciles, those groups of patients, even groups, and looked at each little decile, how many events they had compared to what the risk score was predicting. So really, it varies around a little bit and maybe more at the higher end, but pretty consistently above. And this is for men. For women, and you can see for men that the Reynolds risk score does extremely well, right? It's almost all the way on the line except for this one decile that didn't perform well. For women, this is the risk score again. Here you really see that effect, that it's kind of the higher risk women that it didn't perform as well as the lower risk. How about what is most clinically relevant? So we produced this graph. This is really the group of patients I think that we think hardest about. This is a calculated risk between 7.5% and 10%. Remembering in the guidelines that 7.5% is kind of that cut point. Certainly for using statin medication for risk prevention in the guidelines, and many aspirin guidelines for primary prevention when you're trying to balance taking a risk of bleeding with preventing a cardiovascular event. You want to know how much risk they're at. 7.5 is a cut point. When we look at that group, all the men in MESA that had a risk of 7.5 to 10%, so the average kind of being in between, the actual event rate was way down here at 3%, less than half. For women, not as much, but still significantly left down here at 5.1%. So I think that this is something important in the patients that we will be seeing in this kind of decision-making category. The next question is, well, how many people are actually in that category? Is this going to have a big public health impact? This is the NHANES study. This is a study that's run by the CDC, really to keep track of risk factors, prevalence of risk factors in the U.S., and they do surveys every few years. And the most recent data that we had and were able to look at was between 2007 and 2010. This is people's calculated risk. Now, it's not 7.5 to 10 like I wish it was, but it's just greater than 7.5%. These are all people who would have a new calculated risk score of greater than 7.5%. You could see that it goes up greatly with age, but it's pretty consistent across men, women, whether you're white or African American, that as you get older, your risk of having this greater than 7.5% basically hits 100% at some point. Is this a lot of people? Well, it's estimated that 56 million American adults age 40 to 75 are eligible for statin therapy under the new guidelines. This is a huge amount of people. Not all these people meet the eligibility because of a risk of greater than 7.5%, but as I'll show you, it's a large percentage. So this is from that same estimate. This is a paper that came out in the New England Journal shortly after the guidelines. This area here in brown are the percentage of people age 60 to 75 that qualify under the new guidelines for statin therapy compared to the old guidelines. So it's a lot more people, and if we're not estimating this correctly, it's going to be treating a lot of people that may not be getting the benefit that we think they're going to have. Okay, so far all I've talked about is calibration. But discrimination I haven't talked about, and this is what I think many of us are familiar with ROC curves, where you see basically a test overall performance for being able to diagnose an event. The event here is having a cardiovascular event, one of the events that the risk score is trying to predict. Right? No one has a cardiovascular risk ultimately of 10%. They either had an event or they didn't. And this is looking at how well these risk scores discriminate who's going to have an event and who's not over 10 years. And you could see really between all the risk scores, no difference. Okay? This is a coin flip here, 50-50. A perfect test would be way up here, right? Would be able to tell the difference. And this is somewhere in between. Risk prediction with using risk factors is not great. It's okay at best. And it's always been around the low 70s, and it's really hard to move these lines. But we certainly wanted to see if the new risk score was adding something special, and we should tell clinicians to stop using the old one, start using this new one because it's so much better. We didn't find evidence for that for men or for women. I think one here stands out as not doing as well. It's the old Framingham risk score. Doesn't do well in women. It was not a surprise. But really, the point here is that none is showing superior discrimination. So we're left with, do any of these show superior calibration? Okay, so why? Why do all these risk scores overestimate risks in our patients? One thought was medication use. Right? If you enroll everyone on day one, get all their risk factors, and by year 2, they're all taking statin therapy, well, maybe it's the statin that you're not accounting for in your risk score because you calculated on day 1 that their risk is so much lower. So we did what's called a sensitivity analysis. Now, the purpose of a sensitivity analysis is not to stratify the groups and say, oh, that the risk score is so much worse or better or so forth. It's to see if there's any evidence, any inkling to drive the hypothesis that medication use is what is explaining your risk overestimation. So we eliminated everyone that ever touched any sort of therapy that could be considered cardiovascular disease prevention in the cohort. We included aspirin and any cholesterol-lowering medicine, blood pressure medication, any revascularization procedure. If you went in and had a stent placed or something, because that potentially could lower your risk of having a future event. When we removed all those patients, risk overestimation remained high. Now, these numbers are really high, and we could talk about why, but I do want to make the point. We're not claiming that this is a new point estimate. We're just claiming that there is no evidence that it was the medication that is really to blame and or explain the effect we saw of overestimation. We'll come back to that. Limitations in our study. Well, you're always worried about missed events, right? You're following these people for 10 years. Maybe they had events we didn't know about. That's a limitation to all the cohorts used to produce these risk scores. We think that the methods in MESA for tracking down and adjudicating events was at least as good, if not superior, to those studies used to produce the other risk scores that we analyzed. However, we pushed it a little further. We did a sensitivity analysis. We looked at CMS claims database. Something that's typically not missed is billing someone for a diagnosis. However, the accuracy of this is not known, right? Whether this is just an elevated troponin that wasn't a real event is hard to know. Nonetheless, we looked at all the participants in MESA that were in the CMS database, so they had to be over 65. It was about half of them, 3,000. And of those 3,000, they had 160 MESA adjudicated events. Beyond this 160, there was 16 billable diagnoses consistent with ACS. And so when we added those in a sensitivity analysis, as if they were events, we didn't try to adjudicate those 16, so forth, it really didn't make much difference. There was no real difference in how much overestimation the new risk score still performed. So that didn't seem to be a big problem for us. Healthy cohort effect. people who agree to be in studies are going to be healthier. They're going to exercise more. They're going to eat better. They're going to follow up with their doctor more. Again, a limitation that we see in all of the cohorts. Shouldn't be any different for MESA than any other. Any evidence against that? Well, we did find this study in Germany where subjects were not asked if they wanted to be in the research study. So no selection bias here. They enrolled patients in 2000 and 2003. They were randomly selected by this study. And they found a very interesting results. They also found that the Framingham risk score overestimated risk by more than twofold in the 93% of randomly selected subjects that didn't have any baseline cardiovascular disease. So the population for which we're trying to risk predict. Okay, so this project didn't come without its fanfare. It got a lot of attention in the popular media, which was a lot of fun to talk to people and really get the word out about our findings. However, the guideline writers were not seemingly so happy about the results and their critique of their new risk score, which we basically said is no better than what people are currently using. And this is not published yet, but will be. We were notified that both the guideline writers' response to our publication and our response to their response, if I said that right, will also be published soon. So they had 4 poignant comments, which of course have some truth to them, and I wanted to go through those quickly. So they first said that MESA participants have undergone coronary artery calcium scoring at least twice during the study. And then participants were told, they got a letter that outlined what their coronary calcium score was, and simply told if they would like to talk to their doctor more, they can. But no treatment recommendations were made by MESA, and the physician themselves were not informed of the patient. And they felt that, and we've also shown in MESA that patients who went home with a letter that had a high calcium score were more likely to start a medication than those who had a low score. And they cite this reference here, and they say, well, that biased our results because this undoubtedly contributed to underperformance of MESA event rates compared to the predicted natural history. I still struggle with how you underperform in having heart attacks, but nonetheless, I think what they meant to say is that overprediction was due to the fact that it was a healthier population. So here's the study that they cite. Oddly enough, it has both investigators from our study on it, as well as the guideline writers. And it does, in fact, show that if you went home with a very high calcium score, greater than 400, which is pretty high, as compared to having no calcium in your arteries, that you were more likely to be prescribed a medicine. However, this effect was not really sustained. Follow-up looking, people were not more likely to stay on their medicine. And I think more importantly, although this study demonstrates that you were more likely to be started on a medicine, it certainly is not evidence that knowing your coronary calcium score is related to how many events you have. And I think that's important because coronary artery calcium is, and hopefully we'll have some time to talk about it a little bit, there is no evidence really, and that's what's holding it back in the guidelines from recommending it for screening patients and saying that this is what we're going to use to prevent your cardiovascular events, because there is no randomized controlled trial data on that. And then finally, we point out that if coronary artery calcium was to blame, it would have to prevent almost half of all the events we saw in MESA to explain the overestimation. And that just seems unrealistic. Number 2, the use of preventive therapies in MESA cohort is extraordinarily high compared to the U.S. population, as we show in our paper. From baseline to follow-up, aspirin increased, all these medications increased. It is therefore impossible to use these data to evaluate the accuracy of estimated natural history risk. Well, a couple things to point out. So first, when we say 25%, they meant this is what people were on at baseline in MESA. And then follow-up was a very conservative estimate by us, which is at any one of those 5 in-person visits or any one of 14 phone calls they said they were on or had taken the medicine, they were included. That is not the same as saying at any one time we had 60% of patients on lipid-lowering medicine. Okay, so it's a little inflated, and we'll go through these numbers in a little bit more detail. And then as far as natural history, it's, you know, I struggle with this. This is true, you know, when you predict risk, but in the real world, I mean, what else are you going to account? What if someone goes on a diet? You know, is the prediction no more any good? If they start exercising, they start taking a baby aspirin, you know, our patients, and we were trying to see how well this risk score would perform in real practice. So first, we don't think the use was extraordinarily high at all. We think it was very reflective of what our patients are actually doing and what our patients are coming to us on. So if you look at the baseline, you know, NHANES, this survey of the entire U.S. population. If you look at blood pressure in the same blood pressure medication use, and we compare the same age group, over 40, 30% of U.S. population over 40 at the start of MESA was on blood pressure lowering medication. In MESA, 31%. That was their baseline value. Excuse me. Cholesterol lowering medication, NHANES also has data for that. In 2003 and 4 was the first time they collected it. It was 20%. In 2002 to 2004, when we were enrolling, it was 19%. This was actually follow-up exam 1 when we asked. So pretty close. These numbers do go up. So when NHANES redid these numbers in 2011 and 2012, it went up to 28%. At that similar time point in MESA, it was a little higher at 34%. But we certainly don't think it's extremely different from what we're seeing in practice. Okay, number 3, personal attack. DeFilippis attempted to account for the use of preventive treatments with several methods, all of which are flawed. Simple statistical adjustment for use or censoring at initiation of therapy clearly do not account for treatment effects. The approach of excluding all participants who had ever treated yielded a highly biased analysis subject to major confounding by indication. Furthermore, only 14% of the 218 observed events occurred in the untreated individuals, leading to highly unstable estimates. So some of this I agree with. The purpose of the sensitivity analysis was not to come up with a new point estimate, because it is unstable. What it was, do they have any evidence at all to support their claim that it's medication use which is causing the overestimation? And the most objective way to look at that is with a sensitivity analysis. And the analysis didn't find anything to support that point estimate. So that was our conclusion there. We don't have too much more to say about that. The last point is they appear to have included Chinese and Hispanic Americans who comprise 1/3 of the MESA cohort. And the guidelines say that this new risk calculator is only recommended for whites and African Americans. Okay? With a recommendation for others, the guidelines noted that the equation would overestimate in Hispanics and East Asian American groups. A more appropriate, we couldn't show everything. We had 14 tables in this publication already. But my point is, again, we're trying to see how this works in clinical practice. If someone walks into your office, should you use the risk calculator to estimate the risk if they're not white or African American? Furthermore, they've made a very strong argument that although their risk score doesn't estimate risk better, it's not better calibrated, and they can't show that it has better discrimination, it's now better because they have a variable for African Americans, and we kind of fired back, well, it's not enough just to put the variable in there. You have to show that it actually works. So we did, in our response, publish our stratified analysis. Now, I want to caution about the use of this as well. Right? This is a simple stratified analysis, how the risk score predicts risk based on your ethnicity. You could see that risk overestimation, overall is 78%. We show that. It's about 80% overestimation. It got worse for African Americans, the very group that they said that this was advantageous for. They are correct. It way overestimated more in Chinese Americans. It performed okay in Hispanics, which they don't recommend it for, And then, again, just a less worse in whites as opposed to the other groups. So, a couple of things about this being a simple analysis. This doesn't take into the account if, let's say, the real reason that the risk score overestimates is because blood pressures are much better now in 2015 than they were in the 1980s in these cohorts. And blood pressure control is better. And Chinese Americans take a lot more blood pressure medication. It's not that they're Chinese or their genetics are different. So there's no control for confounding here. That is our next study that we'll publish. We're going to look at, when you hold everything else constant, what factors are associated with over prediction of the risk score. And so I wish I had that data ready for you now. The statistical team is still working through that, and hopefully we'll have something for you more soon. Okay, so I'm going to just very quickly go through this. Other people have also shown risk score overestimation. And other than the data I showed where it underestimates risk in women, there's been no cohort where it's been tested now that shows that it's either working very well or that it underestimates. All overestimation. Okay, these are from the guidelines themselves, and they even used data from MESA, but it was only 6-year data, because when they were working on this, it was many years ago, and it was a simple analysis. They didn't do a full-blown analysis of it. And we'll come back to regards. So the women's health study, now these cohorts are all much more limited than MESA, admittedly, or maybe I'm biased because I was the one that did the analysis in MESA. But this is just women, right? It's not an ethnically diverse population. Women's health, the physician's health study, this is what the risk score predicts with the event rate. This is what was observed, the tremendous overestimation. The women's health study, same thing. This is the women's health study where Nancy Cook and Paul Rickard then tried to account for statin use and revascularization. And what they did was they first showed that there was overestimation, and then they said all those who were on statins will increase their calculated risk by 25%, since statins are associated with about a 25% risk reduction. Still didn't really show anything. And then they said, well, maybe those patients that are getting started on their statins because they're at higher risk, their physicians know that, it's not captured. So they took their calculated risk, they doubled it, and then they added 25%. Still didn't quite make it. And then they did the same thing for revascularization and still weren't able to explain all the overestimation. This is a European cohort. And before they get to showing how it's calibrated and if it overestimates or not, they just showed a comparison here of who is recommended for treatment. The red is a treatment recommendation. The yellow is consider treatment, and green is that treatment is not recommended. If you look at adults 55 to 65 in this cohort, almost all the men are recommended to be treated as compared to a sizable portion of women. And they compare this to the older U.S. guidelines and to the European guidelines, which are clearly more conservative. If you look at an older age group, it's even worse so, right? Every male over the age of 65, but not yet 75, in this cohort, treatment would be recommended if you calculated their risk score. This same cohort, European cohort, again, predicted risk, observed. Predicted, observed, above for all of them. The risk factor, right, or the guideline writers for the risk factor did do their own study. I'll mention it here briefly. It's looking at regards. Regards is the most modern cohort, but because of that, they only have 5 years of follow-up. So it's evaluating a 10-year risk score with 5-year follow-up. Heart failure, they were unable to exclude it really because they didn't ask that question at baseline. This was not designed, this study, for risk score calculation. They simply they said they were able to get all the heart failure patients out by excluding anyone who was on digoxin, because we know that all of our heart failure patients take digoxin. And then what they did was they found overestimation, and they said this was due, and this is where we got our CMS idea, was due to a lack of capture events. And when they threw in all the CMN claims, unadjudicated events, It got closer, but not perfect, and that's that data there. So I wanted to leave a couple minutes for why I think these risk scores overestimate and what to do about it now. So why I think is because these risk scores were developed from cohorts that are a quarter century old. And this is a moving target. Things change, right? Diets change, the way people exercise, air pollution that several people here at this university work on. Ethnic diversity of the country is different. Tobacco use, in the 1970s and 80s, smokers smoked 2-3 packs a day. These days, that's not as common. Data shows that. What's in cigarettes is different than it was in 1970 and 80. And so it probably affects our cardiovascular risk differently. Many other factors that we're not measuring. The Reynolds risk score performed fairly well. It was the most modern cohort of the ones tested here, and that may account for why it performed better. In summary, quickly, we showed that basically these risk scores that are based on older cohorts overestimate risk. The Reynolds risk score performed pretty well. That overestimation was out throughout the continuum of risk, maybe a little bit more in the high-risk patients. And discrimination, that ROC curve, was no better with the new risk score than the old. We think that this has real implications, right? Both for balancing side effects of rhabdomyolysis or myositis or bleeding from aspirin use on an individual patient basis, as well as real implications for resource utilization in an already financially strapped healthcare system. What do we do now? And we're running out of time, and I won't go through everything. I wanted to point out a few things. So the closer you are to the event, the easier it is to predict. We're way back here at risk factors with these scores, right? Trying to say who's going to actually develop the disease. And now we have measures of early vascular damage like CRP, the most well-studied of early vascular damage. It's in that Reynolds risk score, maybe another reason why it performs a little better. But there's other things, microalbuminuria, FMD, carotid intimal thickness. And then there's actual measures of the disease process itself, whether that be a plaque that you see on a carotid ultrasound, or the most well-studied is coronary artery calcium. I'm going to skip that. So you could see that as disease progresses, at some point, in most patients, and not all, they'll have buildup of calcium in that atherosclerosis before they have a rupture and an event. And that helps to predict who's going to have an event. This is a picture that, you go through a CT scanner, it's about 1 millisievert of radiation compared to about 25 millisievert for a nuclear stress test. This is about the same as a mammogram. And you can see here, this is a CT scan of the heart, and this is the coronary artery coming off the aorta, and you can see that this one's got a lot of calcium in it. And this could be added up, and you can get a score. It's pretty easy to do. And this score is certainly related to who is going to have a cardiovascular event. This is over 5 years, looking at people. This is in comparison. Now, it's also the only thing out of a long list of things that moves this discrimination curve. Okay, so this is the ROC. This is the Framingham risk score plus coronary calcium score or plus everything else, C-reactive protein, family histories, monointimal thickness. So before I tell you what I do, I think I need to point out just 3 other things to consider. The first is, although the guidelines, and it makes a lot of sense, that you want to give therapy to those that are at the most risk, there's no clinical trial, statin trial that was done that said we're going to enroll patients, and those that have a calculated risk of 7.5 or greater with the new risk score or any risk score are going to get statins, and those who don't are not. It has not been tested in a randomized trial. That's the criticism that the coronary CT scan is under and why it's not in the guidelines. There's no, and then the other is a little bit to challenge. Almost all the data says, right, the higher the risk, the more the benefit for statin therapy. But there are some exceptions. There was 2 large trials that come to mind right away in statins. So Corona was a trial of statins in patients with heart failure, including ischemic heart disease. Made no difference if you were on high-dose statin or not as far as having events. And the same for if you, in the Aurora trial, if you had end-stage renal disease. So what do? I've kind of, the pendulum has swung for me. I was a real proponent of using these calculated risks until I objectively evaluated them. Now I kind of am back to the art of medicine and using all available information. This is a review I wrote in 2007 called Clues to Cardiovascular Disease, an Office-Based Approach, where we went through kind of all the things that are not all, but the most common things associated with cardiovascular disease. Right? If someone has rheumatoid arthritis, they're at increased risk. It's not in any risk score. You have to consider that, right? And it shouldn't be in a risk score because that's not so common throughout the population. The risk scores have to be easy to use and a starting point. So I think you need to consider everything. You got to take a good history and think of all these things that are related to cardiovascular disease. Physical exam markers like a widened pulse pressure, ankle brachial index, waist circumference. These are all things that we know are associated with higher cardiovascular risk. Seeing calcification of the aortic knob on a chest X-ray, laboratory values. I think that you should try to use the most contemporary risk score calculators. This is a moving target. MESA will come out with its own risk score, but it won't be any good in 15 years. It'll have the same problem. And this is an issue. NHLBI has announced that they're not funding these long-term cohort studies anymore. And people are arguing back. And one of the strong arguments is that risk factors and how it affects cardiovascular health is a changing target. And I think we need to keep that in mind. I think this data proves that. And then finally, for people who are tough decisions, using advanced measures of subclinical disease, so evidence of actually having the disease, how the risk factors affect that individual patient before they have an event is useful, and I think that even though it's another talk, I think the data is strongest for coronary calcium scoring. That's all I had. Thank you.
Andrew, very well done.
Thank you.
So in Grand Rounds last year, I talked about if we're going to move the pendulum into increasing health index or improving health index in the state, we can't just be seeing patients day in and day out. We want to make a difference. We got to deal with disease prediction, risk factors, discovery, and implementation for population health. And this is a first step to doing that. So appreciate you doing that. Number two, I want to remind the audience what Roberto just said. Andrew is an outstanding clinician. He just won last year's Cardiology Division Teacher Award. He's engaged in very relevant clinical research, and we appreciate that he's sort of a visible example of what a triple threat is in academic medicine. Now, now the difficult one, okay? And I won't be as bad as the guys who you didn't know what you were doing. So I'm a pulmonologist, and we don't worry about risk factors for COPD. I mean, we think about smoking as it's a major risk factor, but we don't spend our lives thinking about criteria for development of COPD. No, you haven't seen a study saying, what are the criteria?
The lungs are not as important, Jesse.
That is true. That is true. You'll find out when you meet with me tomorrow. I'm half joking, but I think the difference is that we consider COPD a chronic entity that once we can identify, we don't even know where to start. We identify about pulmonary function test or CT scan. It's a chronic entity, and that a COPD exacerbation is not the event to predict. It's the risk of developing COPD. And here, I equate MI as a COPD exacerbation, as opposed to what you mentioned at the end, that this is an entity that has been going on for a number of years, and perhaps we should be looking at how to predict the disease as opposed to the event. Tell me what you think about that.
I completely agree, and have done quite a bit of work in that we try to predict the appearance of coronary artery calcium, a measure of subclinical atherosclerosis, and MESA is clearly a leader in that. And we've also tried to predict progression of coronary artery calcium, which is a little bit more controversial. But you're absolutely right, and that's what I put up this slide here, if I can go back to it, right? We want to predict the occurrence of this entity, not the event. And there's a lot of different measures out there for doing that now. I will say that they all agree, meaning, and we've looked at this. In fact, my first comparison I made of risk scores was the Reynolds risk score versus the Framingham risk score in MESA before I had 10-year event data on the occurrence, the incident, and progression of coronary artery calcium. And the scores do well, and all the risk factors are related. So the story is consistent in this progression as I line it out here. First, the risk factors. The risk factors put you at greater risk for having early vascular damage. If you're a smoker, you're likely to have a higher CRP. If you have high cholesterol, you're more likely to have microalbuminuria. And then if you have these vascular markers of vascular damage, you're more likely to develop subclinical atherosclerosis as measured by, a carotid ultrasound or measured by a coronary artery calcium scan. And now the CT, although we don't have this data in MESA, the Miami Heart Study is going to really be the first to really look at this, and it's starting up in a couple months. By CT scan, we could actually look at plaque now. The CT scanners are good enough that we have an idea of soft plaque without calcium in it. But that continuum, all the science to date in cardiovascular science, is that continuum is preserved, and one predicts the next.
Okay. Let's start here and we'll go around.
Right. I mean, age is a very strong driver of having an event, right? A cardiovascular event. There's no question. And this points out exactly what you're saying, right? When they looked in adults just 65 to 75, which is not that old, by the new risk score, 100% of them meet this criteria. The guideline writers argue back that cardiovascular event is what's killing these older adults, and it's all about absolute risk. There's less. There is, and the name of it is blanking, is from my mind. But there was a study of statin use in octarians with pravastatin, actually, which is one of the less potent statins, that showed a risk reduction in older adults. But again, of course, and no one would argue this, including the guideline writers, that the decision to treat with a medication is not only having some objective evidence, but also talking with the patient and knowing what their goals and risk factors are for taking that medication and making a decision. And maybe it's a topic for another time, but I've also done some thinking with a group of people who think that maybe we should be treating relative risk rather than absolute risk. But the guidelines are very clear on treating absolute risk.
The hour is late. Those who have to go can go, but we're having too much fun here, so let's go. Come on.
Yeah, so this data is new for me as well, and I tried to do that at the end. So I used to base everything on the risk score. I am now going back to using the Reynolds risk score. It is it's based on the most contemporary cohort, and I think that makes a big difference. It was initially done in women, but as you know, it's been validated in men. You can calculate it with and without a CRP. It adds some, but not a ton. But I think that using the Reynolds risk score, and then I adjust that risk score based on that list of other things. If a male comes to me with some cardiovascular risk factors and also has erectile dysfunction, the positive predictive value for him really having underlying atherosclerotic disease is very high. And even if the risk score is less than 7.5%, they're leaving with comprehensive risk factor modification, including a discussion about an encouragement to use statin therapy to reduce that risk. Yeah, there's the extremes, right? Rita Redberg, who's the editor of JAMA Internal Medicine, has 50 articles saying that we shouldn't treat anyone that who hasn't already had a cardiovascular event with a statin, right? So clearly, the amount of benefit you get is associated with your risk, which we talked about in the beginning. And the number needed to treat for people who have had an event is can be measured in the 20s, depending on which study you look at. As your risk gets lower, that number gets larger, and it becomes, statins are so safe that I don't think it becomes a real problem for patient safety. But it's really a question of how you're going to utilize those resources in the healthcare system. Talking about seeing a 45-year-old in your office and subjecting them to 45 years of statin therapy is something to consider. I think aspirin is much harder, right? And the data is really not that great for primary prevention, but there is a real measurable risk of having an intracranial bleed because of the fact that you were on a baby aspirin, and trying to balance that. Even though that risk is low, it's catastrophic, but literally, for all intents and purposes, everyone is dying of cardiovascular disease compared to everything else, and which is why it's attracted me to looking at this topic, and why 53 million Americans becomes a big number. I think ultimately, to answer your question, I think the way around that and the way around the age is to treat people based on relative risk. So instead of treating people on absolute risk, when you see a patient, is for your age group, what is your relative risk of having an event compared to if you didn't have any of these cholesterol problems, blood pressure, et cetera?
Last question, is there one? If not, thank you very much. Very good.
Thank you.